All right, here we go. Oh, I have a guest. Let me admit her. Okay, welcome everybody and good evening. We are in the midst of celebrating Black Maternal Health Week 2021. This week was founded and is currently led by the Black Mamas Matter Alliance. And I believe this is the fourth annual Black Maternal Health Week. April in general is Minority Health Month. And I thought it fitting this week to have a conversation dealing with Black maternal health with an expert who I so much respect and revere. She's a friend and a colleague. Her name is Dr. Sascha James-Conterelli, and I'm gonna read her bio in just a second so everyone can get to know her. And then I'll allow her to give us some opening remarks, and then we'll get right into our conversation. But Sascha and I have known each other for several years, and she's accomplished so much. I'm so very proud and pleased to have her, that she agreed to come on here and chat with me and share with you guys. So I'm going to go ahead and read her bio. Dr. James-Conterelli received her bachelor's in nursing from Howard University. Big up to the HUs. So I'm the other HU, right? So we do get along, folks, okay? We do get along. There's hope, all right, with the Hampton-Howard rivalry. And her master's is in midwifery. So she is a certified nurse midwife. And her doctorate degree is from NYU. She's been a nurse for 26 years and a practicing certified licensed midwife for 19 years. Her professional journey has been unique and broad-reaching, with practice settings in both public and private sector, providing her with diverse expertise and background. Political advocacy and systems policy has underpinned her clinical work, opening doors to exciting opportunities for advocacy of midwives and midwifery to be recognized as invaluable stakeholders in global perinatal care. She's a full-time faculty member at Yale School of Nursing, as well as the chair-elect of the Graduate Entry Pre-Professional Nursing Program. She also continues to maintain her clinical practice as a member of Yale Midwives. She has served the past 3 years as the first Black president of the New York State Association of Licensed Midwives. And she is also honored to have ongoing opportunities to provide knowledge and expertise to many national efforts, such as the CDC Maternal Mortality Review Information Application. That's a mouthful. Bias work group, okay, but very important work. This work group successfully updated the abstraction form to include factors of racism and discrimination that may contribute to a maternal death. She is the only midwife member of the New York State Perinatal Redesignation Task Force. This task force is comprised of multidisciplinary experts that work together to redesign the structure of perinatal service delivery across New York State by ensuring birth facilities are appropriately designated according to services and the staff available. They also work to create a network of service providers to address the current and emerging perinatal needs across the state. She's proud to serve as co-chair on Governor Cuomo's Maternal Mortality and Racial Disparities Task Force. She's a member of Governor Cuomo's COVID-19 Maternity Task Force, as well as a member of New York State's Maternal Mortality Steering Committee and New York State Maternal Mortality Review Board. I told you she was qualified for this conversation. Okay, and she's also a member of the New York State Postpartum Work Group, as well as the New York State Birth Equity Improvement Project. As a proud West Indian, now you see we have so much in common, right? She recognizes the importance of global outreach and has dedicated efforts towards assisting the midwives and perinatal community in her home of the Virgin Islands and Puerto Rico. And with that, I will officially introduce Dr. Sascha James James-Conterelli as we have our conversation this evening. Welcome.
Of course, you definitely are better not call me doctor or anything. Dania, we've known each other for so long, and uh, what folks don't know is we have great, deep love for each other. Dania and I go way, way back, working alongside each other, supporting each other on his journey. And as she's proud of me, I am extremely, extremely proud of her beyond, and that's deep and heartfelt. And so you read a really long bio about me. Basically, I'm a midwife, and I love what I do and embody what I do. I define myself as a midwife, so it's not just my job; it's my life. And so doing all these other things are just part of my life's work. It's not um, extra jobs. And yes, Howard and Hampton come together. Dania and I frequently make jokes. Even our colors are the same, which is wild that they even pick the same colors. But it can happen, and we can get along as HBCUs. And that all that really boils down to is professionals that we promote each other's excellence. And so that's what we do.
Awesome, awesome. Thank you for joining us on Conversations with Dr. D. So you mentioned that you are a midwife. You embody that always in everything that you do. Why did you decide to become a midwife?
It's interesting that you asked me that. From the time I was a child, like every other little West Indian child, your parents give you like 4 professions that you can go into. And that's either,
Don't they?
yes, you can either be a doctor, a nurse, a teacher, an engineer, or a lawyer, something like that. That's all we can ever do in life. And my mom actually is a retired physician. So from the time I was a child, I always saw her medical books. And I always looked at obstetrics and gynecology. And I could say that obstetrics and gynecology from the time I was 4. I remember being able to do that and asking her many questions. I was always an inquisitive child. I asked her questions, and I always asked her why, to the point that she told me, because I said so finally. And as I grew up, and I didn't want to go into any of those professions. Actually, I wanted to go into fashion. And as a true West Indian woman, my mother was like, you'll never make any money, so you're going to go into nursing. So I went into nursing. Even as a physician, my mom promoted me going into nursing and the reason why she said that is because she said, once you become a nurse, you can do anything. Mm-hmm. Nurses are everywhere, and you could do anything you want to do. And I went into nursing and fell in love with nursing. And when I graduated in the late 90s from nursing school at Howard and came back home to New York, that was the time when all new grad nurses were put on med-surg units, medical surgical units. Mm-hmm. And I was on a medical surgical unit at NYU. And it was a non-teach unit, so it was quite unique. There was no residents, it was just nurses. We ran the unit, and we had a step down. And it was an HIV oncology unit, and we did stem cell transplants. And so while I learned a lot and I became independent and I had a lot of autonomy, I realized that oncology was not my calling. I felt like I was going to work. Even though I loved what I did, I felt that it was a job, and I just couldn't see myself doing that all the time. And it brought me back to my college rotation of midwife, perinatal healthcare, and I was taught by a midwife. She was from England, and I decided to go to labor and birth. And when I went to labor and birth, from the time I stepped on the unit, I realized this is what I want to do. Mm-hmm. And I wanted to be a provider. I thought I wanted to be a physician. And then I found out what obstetrician and gynecologists do in the United States. It's very different from what my mom and grandmother says that obstetricians and gynecologists do in the Caribbean. And so when I had that discussion with my mom and my grandmother, I found out that what I wanted to do aligned more with midwifery. So lo and behold, I went to NYU and became a midwife. And during that process, I never looked back. It was exactly what I wanted to do, was be a midwife. But in the United States, being a midwife is not as revered as it is in other countries, even in the Caribbean. So herein starts my journey of maternal mortality and racial disparities. Again, in the Caribbean, the majority of folks are brown, so they don't look like us. When I came to the United States as a 10-year-old child, I didn't know that I was Black, and I didn't know that being Black was bad. And until I found out from folks quickly and cried to my mom a lot about it. Because where we're from, Dania, all people look like us.
Exactly.
No
Yeah.
matter what shade of brown, right? We're all the same. And I realized quickly in healthcare that how you appear changes your trajectory in healthcare for some folks. And that to me was innately wrong.
Yeah.
And if I had the wherewithal and the education to impact that in any way, then that's what I would do. So that's how I went into midwifery, and that started my my trajectory that I'm on. It says my connection's unstable. Am I frozen?
You're not frozen right now. You went in and out a little bit, but still audible, still legible.
Okay.
So I'm glad that you mentioned something that's really important, especially to acknowledge this week. And why is there a Black Maternal Health Week, right? You mentioned that based on how your appearance, right, your race, something that you can't change about yourself, you may be perceived certain ways by other people. And so Black Maternal Health Week was a way to basically have a rallying cry around the disparities that we're facing as Black women, Black and brown women have the highest rates of maternal mortality and morbidity. And it's the basis for that is basically what you just mentioned, right? The discrimination based just on your race, right? Which is, we know, is also a social construct and has nothing to do with your biology. But here we are, right? And so this conversation, I'm so glad I have you here as a subject matter expert to kind of share the work that you've been doing on the various task forces and all of your different appointments and through your research and your practice, right, to talk to us about where do we go from here, right? That's what this episode is entitled. But to delve a little bit more into your journey now from midwife to more of an educator and advocate in all these various roles that that were mentioned from your bio. Talk to us a little bit about that, how that transition happened. How'd you get involved in all these task forces, Sascha?
I have a big mouth. So Danger knows that also about me. So I mentioned that I was a very inquisitive child, and that never went away. My mom actually fostered that, and so did my family. And I think generationally for us in the Caribbean, there's never been that you can't do it. It's always, you can do whatever you want to do. Mm-hmm. And so when I became a midwife, and I thought bedside, one patient at a time, I could make a difference. Again, folks saw something different in me. I always say I have a loud mouth, but it's just because I question systems and systems of oppression, and I have no problem writing an email or knocking on a door, and I'm not intimidated by letters after your name, and I'm going to ask the why, because I need to understand the why. Why is it that a policy or system that you have in place is negatively affecting the end user, which is your consumers? How could that possibly be beneficial to anyone if you have someone being negatively affected? So to me, one maternal death is not acceptable. None is acceptable, right? Mm-hmm. And so I had the opportunity, and I've been presented with opportunities and tapped to get into policy and procedure, to offer opinion, to offer insight, and to have the real discussion of the lived experience of a person of color from traditionally marginalized populations. You mentioned that I'm from the Virgin Islands, and my mom's Trinidadian, and our next door island is Puerto Rico, so I speak Spanish as well. For Black and brown folks, things look very different in healthcare for us, and it shouldn't be. I shouldn't worry about doing something that's so innate to humans as bringing forward new life and adding someone to my family. That shouldn't be a scary process. There's fear in that in and of itself, because there's a journey and a transition into becoming a parent. But I shouldn't be afraid that if I get pregnant or have another child, that I'm going to die. And I shouldn't feel, there shouldn't be fear associated with seeking something so very, that is your basic human right, is healthcare. And that is what the fear that many Black and brown folks in America, they carry daily and for generations, and it's passed down. And it manifests pathophysiologically as when they show up in a space that you start to see elevations in blood pressure. Then you start to see changes in their affect. Then next thing you know, we have high blood pressure. Then here comes diabetes along with it. And because they're scared because I might kill them or they might die in the hospital, that they bleed because their bodies don't release the appropriate hormones, and your body won't do what it's supposed to do. And then it just spirals down into a death or a near miss. And that's completely unacceptable. And so to me, rising to the occasion of accepting positions to influence change was the least that I could do. Is to sit at the table and to continue with my appearance and in the space to remind the folks that make the policy that it's affecting folks that look like me. And to remind them that you should be cognizant of your end user, your consumer, of the policies that you make. So that's where I am.
Yeah, no, absolutely. I just want to go back into listing a couple of the different roles that you've served as, president of the New York State Association of Midwives. You've been appointed to the CDC Maternal Mortality Review, and also Governor Cuomo's task force on maternal mortality and racial disparities. And also the New York State Maternal Mortality Steering Committee and the Mortality Review Board. So can you tell us a little bit maybe about your primary functions in some of these roles?
So I'm very lucky and blessed, is what I call it, to have had the opportunity to serve my midwifery community locally in the state of New York as the first Black president, the first president that is a BIPOC member for New York State Association of Licensed Midwives. Midwives that represent over 1,200 midwives in the state of New York, is one of our largest state affiliates for the National Organization of American College of Nurse Midwives. And so I was very, very blessed to be in that position, and I served in that capacity for 3 years. But while I was in that position, I had the opportunity to be tapped for the Governor Cuomo's Maternal Mortality and Racial Disparities Task Force, as the governor changed his women's health agenda to focus on maternal mortality and maternal health issues and women's health issues in general. And so it was a unique task force in that the co-chairs of the task force were 3 women of color. Myself, Wendy Wilcox, who is the Director of Obstetrics and Gynecology for Kings County, and Dr. Danielle LaRocca-Reyna, who is a pediatrician in SUNY Albany. Of course, the head of the entire committee was Dr. Howard Zucker, who was the commissioner at the time. But it's unique in that the governor has never had a task force that was completely led by folks of color and 3 women of color, and from diverse backgrounds. To have an obstetrician, a gynecologist, a midwife, and a pediatrician sit at the head and lead one of the largest one of the largest steering committees and task force in the state, was a monumental and powerful move by him. And we met for over a year and a half in order to provide him with a multi-pronged approach to address the crisis that we have in New York. Because when we started, New York City maternal mortality rate for Black women was 12 times the rate of that for, and this is college educated Black women, 12 times the rate for high school educated white women. And that is astounding. And right now it's decreased to 8 times the rate. But when we started, it was 12 times the rate. And so we worked on those recommendations to the governor. And the very first recommendation was to ensure that a maternal mortality review board is state law and is funded. It's not something that goes by the wayside as a second thought. There's a system in place that will always ensure that the women that selflessly gave their lives to promote what is healthcare and bring to light the discrepancies, the injustices we have in healthcare, that their deaths do not go unrecognized, that their deaths were not in vain. And that, not that we publicize their name or their story, even though we know their story, that we learn just what it is that's causing Black and brown women to die at the rates that they're dying. Now that's if you help the folks that are dying at alarming rates, of course, everyone else will be helped. So the most vulnerable members of your population, and I truly believe in that, if you support the most vulnerable members of your population, the entire population will succeed.
Absolutely, absolutely.
So that was my role. But then as we continue on, it snowballs into, because this is a multi-pronged approach, when you're looking at maternal mortality, and we say that there's systemic racism, because we talk about that, right? Systemic racism now. How is it that when we're reviewing a maternal death, that we can identify issues that can lead or identify issues of systemic racism and oppression or discrimination? And that's what a CDC's group is called, the Maria Forum. It's lovingly called the Maria Forum. Of us coming together to look at, how do you conceptualize racism and discrimination? How do you define it? How do you create a theoretical framework? And this is from folks that know research, just using those terms.
Basically, like, because you're coming at it from the angle of after the issue, after the incident, right? After the death, the unfortunate death, you're going back now to review what happened, what could have been done better. But how do you check off a box that says, okay, it was racism that was causing it, right?
Yeah.
Which is what you're saying, basically.
Yeah.
Like,
and so what's behind that box?
Identify that racism was a part of the problem, right?
Yes. And then when you check that box, so what do we do about it, right? What do we do about it at different levels? At the system level, at the provider level, at the policy level? And if you don't have something behind it, defining it, adding substance to it, because again, race is a social construct. So how do you define racism then, right? If race is a social construct, how do you define racism?
So literally, you have to say it doesn't exist,
right?
So you have to substantiate it somehow,
right? Yeah. So that was our goal, and we successfully did that. Came together to define what we know as racism and discrimination. It went through multiple other iterations, and this is a diverse group of folks from around the country and some international input in order to be accepted by the CDC as another iteration of that form. And so that's where I sat as a midwife on that panel, and very proud to contribute to that work that is being utilized, that form that's being utilized nationally now. And of course, with postpartum care, to ensure that families have seamless care as they transition from birthing children to primary health care, right? Because unfortunately, this whole 6 to 8 weeks postpartum magical time that we've been told was not actually evidence-based. It's something that was driven by insurances. And I laugh because it's actually so incredible that we've spread this lie to folks that in 6 to 8 weeks, all of a sudden, magically, you're gonna snap back like they have in movies, and we're gonna all of a sudden be pre-pregnant, and your belly, you should have no six-pack and tight, and you should be running a marathon and breastfeeding and running the world, a company, should be a CEO of JP Morgan and fit in a size 2 somewhere. This is so unrealistic. When it took you almost a year to bring forth this whole new person, you're gonna 6 weeks. What is that magic? So to ensure, and what we've learned from the evidence is that's absolutely a lie. And it takes about a year again for a human to return to almost pre-pregnant state. And within that year, all the risks that can occur during pregnancy can occur during that time too. And if all of us in healthcare are not on the same page, we can truly lose folks that have recently had babies because they will not present the same way pathophysiologically to an emergency department, to a primary healthcare office, because there are different things that hormones affect and present different ways if that's not your specialty. And so to ensure on the back end that folks are covered and we don't lose these birthing people to gaps in care, to extend coverage for postpartum care to a year. So that's my group.
I am thrilled at the announcement that went forth yesterday. I believe it was in Illinois. The state of Illinois has joined in with the movement that has been announced by Health and Human Services to prolong the coverage for insurance in the postpartum period to up to a year, right? And so Illinois was one of the states that has signed on to uphold that and make that promise to their birthing people, because as you said, 6 to 8 weeks just doesn't cut it. Just that, and we're losing folks in that time frame, and beyond. That was awesome. Would you discuss for us or summarize for us the current state of affairs as it relates to Black maternal health? Maybe some of the recent data. What's the picture? What's the broad picture right now in this country?
So you want me to doom and gloom now? We have so many other issues going on in the country, but this is just so important. And the problem with maternal mortality and racial disparities is that if you don't have healthy birthing people, moms, you won't have healthy babies. We won't have a healthy country, and our country will disintegrate. So the state of affairs right now, adding COVID to an already ongoing crisis that is now being brought to light, illuminated, because prior to COVID, we were just really starting to really delve into and talk about maternal mortality and racial disparities in healthcare in the United States. And then we have COVID. And COVID does not silo, it does not discriminate, it doesn't care how old you are, how much insurance you have, or if you're pregnant or not pregnant. And so, of course, the disparities that we're already seeing, they were just heightened by COVID, and we continue to deal with that, right? And so what we have now, we have more families that are unfortunately losing parents, not necessarily to maternal mortality crisis per se as the definition of the 5 leading causes of maternal death that we know of. There are those, but add COVID to it. Add the COVID crisis and the increased deaths that we have in the numbers of folks that are unfortunately not making it. So you already have a traditionally marginalized group, Black and brown folks, that have alarmingly high rates of death and severe morbidity. Add COVID to that, and those rates are soaring. And even if it's not directly impacting them by them getting COVID, close loved ones, losing the father of your child, your husband, your mother, you'll have, and studies are ongoing right now, increased rates of preterm labor, preterm birth, hemorrhage afterwards, hypertensive crisis, fear of going to seek care, delaying care because of fear of COVID, leads to delay in diagnoses, leads to delay in treatment, and leads to unfortunate demise that could probably be prevented. Because what we knew about maternal mortality already was that about 60% of maternal deaths were preventable, right? So if about 60% of maternal deaths are preventable, and then you add COVID on top of that, and add that fear factor that is real, because we all have it.
It's very real.
Right? And you're pregnant, would you be running to your provider, or would you say, especially if it's not your first baby, I'm fine, baby's fine, I already know what this is like, I don't need to go. And in that time span, subtle things could be happening to you. And then when you actually arrive to care, we're behind 8 ball.
Yeah.
Right? So that's the state of affairs. So what do we do about that?
Yeah.
We never lose sight of the fact that maternal mortality is an absolute crisis in the United States, as well as COVID. We never lose sight of the intersectionality between healthcare disparities in general and what we're seeing play out in healthcare right now in this country and the world. We never lose sight, and we don't change the narrative just because of a pandemic. What it does is it helps us to be more laser focused. And what can we do at a system and policy level to really affect, in a positive way, healthcare in the United States, so that we don't lose folks, regardless of a pandemic or not.
Yeah. What would you say, in addition to some of the issues, we know that COVID-19 now has compounded some of the issues, but underlying or preceding COVID, what would you say would be some of the biggest contributing factors to the issues that we're now seeing with maternal mortality and morbidity?
Well, again, I said, we like to say those sexy words of systemic racism and oppression. I mean, for us, because as people of color, it's something we embodied. It wasn't a fancy title to that. We just knew in the pit of our soul when someone said something wrong to us, how it made us feel. We knew when certain policies were written, or if we read something, that meant everyone except us. We knew that if I go to a certain place, maybe I won't get treated the same way as my white sister or brother. And so we didn't have that phrase of systemic oppression and systemic racism and discrimination, but we knew what it was. And so right now, and how that manifests. So there's a sexy term of systemic racism and oppression, and it's absolutely right. And I'm happy that someone coined that phrase. But what it leads to in healthcare is the manifestation. Because race is a social construct, it leads to increased pathophysiological presentation, with systemic oppression of being generational for years and years and years. It leads to what Arlene Geronimus appropriately phrased as weathering, and a change at a very microcellular level of a human that has nothing to do with the color of our outer covering and how we present, but everything to do with the years and years and years of mistreatment and of blatant mismanagement of these bodies, of the bodies that we're in. And so it leads to increased rates of the 5 major causes of not only maternal mortality in the United States, but also some of the deaths in the United States being hypertension and hypertensive disorders, diabetes, clots, cerebral vascular incidents or clots, infection, hemorrhage, right? And those, by the way, are leading causes of death, maternal death in the world. They're globally basically the same. And so what we see is that's what manifests in healthcare. And so then when you see those things manifesting, and they're manifesting really mainly at alarming rates with Black and brown people, you must think, oh my God, well, must be genetic, right? So there's all these studies that say it's our genes. There's something in our genes that makes us have more diabetes and hypertension. And so then you keep feeding that to folks, and then people that are Black and brown say, well, I'm just gonna get diabetes, hypertension, I'm gonna die anyway, so I might as well just do it. When it's reality, it's not true, right? Diabetes and hypertension is not based on your skin color.
Right.
It truly is not. So
I pause and I shake my head because we believed it for so many years.
yes,
It's kind of like incredible now when someone has the way that you're explaining it, and all the psychological things that have gone into the physical manifestations or the physiological manifestations of it. How did we miss this, like, all this time, right? Or how did we just kept buying into it all these years, and now it's like the light bulb has finally gone off, but it's really incredulous to me. Now that you're saying it, and it's like, well, duh.
well, the funny part is, I think, and I suspect that for many, many, many years, people that look like you and I, Dania, have been saying this. It's just that they weren't heard. So I give kudos to the folks that came long before us that were fighting the fight, the same fight that we fought. And I'm sure that I have my two little ones that when they're grown up, they're gonna say, why did you guys even have this? Of course it's a no-brainer. We were crazy even having, why was there even a discussion? Of course, that's what it is. And so, we're just continuing on and illuminating what we've known innately from the time that we were children, right? And hopefully we're getting heard a little bit more.
Yeah.
But to what extent? What did it take for us to be heard? Unfortunately, it took more women dying, more babies dying, to the point that you could not ignore it anymore.
Absolutely. Sometimes in my talks, I refer to it as, the best kept secret, because a lot of people, or a lot of nurses and healthcare providers have been working all this time and really weren't even aware of the magnitude of what was going on. And now, we can no longer be silent. Well, it's the cat's out of the bag now, right? And like you said, those who have, made the noise all this time, and we have finally been heard, thankfully, but now we need to find a path forward, right? So what are some of the strategies that you think can help improve or eradicate the disparities? What are the priorities in this fight?
Well, as one of the New York City leaders for Department of Health and Department of Health and Mental Hygiene, Deb Kaplan said, we need to keep sounding the alarm, sounding the alarm. And I hope she hears me that I said this, and gave her credit, because I heard her in a meeting. I love it. She said, we got to keep sounding the alarm. And that's one of the first steps. And while we're sounding the alarm, we need to change policy, look at systems, look at system breakdowns. This is all at the same time, right? We need to continue to educate our citizens, our communities, that you have rights, you do have the power, you're the one that drives the healthcare system. And while that's happening at the same time, we need to educate our babies that they're all beautiful and equal, and it's not because of your outer covering that you deserve any less than in any way. education, access to care, the right to be whoever you want to be. All that at the same time. And we need to ensure that folks do have coverage, that all folks have healthcare coverage, that there are no gaps in healthcare. Just because you receive healthcare for the first time when you're pregnant, that healthcare continues into primary care. And for the folks that do have, unfortunately, a morbidity, we need to spend time on educating them about themselves, about their lifestyle, about healthy ways of being a human in a non-judgmental way, in a way that's equitable for all, and in a way that really promotes the fundamental beliefs that we say we have in the United States of being diverse and celebrating all the folks that are in the United States as being equal. So it's a lot. It's not easy. It is going to take us a long time, but we have to keep sounding the alarm and chipping away at all of the systems that were put in place that manifest in what we're seeing today.
Absolutely. I have a quick caveat that I'd like to explore. What are your thoughts on provider accountability, right? So now there's this movement to have implicit bias trainings and, trying to have these anti-racist trainings. And, we're giving people the education and raising awareness. But what would your thoughts be on holding individuals accountable who have gone to these trainings, but ... right?
I love it.
Because you could train me to death, right? But if I don't change my practice, right? If I don't internalize that, then we're just going to have these same outcomes. So what would you say about that?
I love it. Okay, so there's two approaches to that because we've had multiple discussions. Again, I told you the governor's tab. It's great because, not only were we diverse, but we were diverse in presentation and walks of life and thoughts, right? So it's a great thing. So we had that real candid and real life conversation, right? Of like, what if that doesn't work? What if someone's just a racist?
Yeah.
Just a racist. And they do believe that folks that don't look like them have equal rights, because there are those folks. So there's two approaches to that. So you approach it through education, one of the reasons why I'm in education, but you start at the elementary level because it has to be a whole culture that you're changing. So you start at the elementary level, infusing it into their everyday practices. We have this thing here called Black History Month. So we start to infuse a diversity across the curriculum, not only in that one shortest month of the year, but throughout the entire curriculum, and talk about the wonderful contributions to math, to science, to geography, to biology. The diverse members of our community have contributed to the advancements of all of those areas. You continue that into high school and in college. So those trainings that you talk about are really for folks that are already in practice.
Right.
And the folks that are in practice that are egregious in what they do, we do have a legal system for them. But some folks that do it and they fly under the radar. And unfortunately, if it leads to a catastrophic event like a maternal mortality, that's where that Maria form comes in. And that's why when we make recommendations, it's at different levels. Is it a system level? Is it a policy level? Is it a provider level? And then there's also patient accountability too. Did we lack, was the patient truly educated, and provided with opportunities? Because there is also human failure, but didn't accept their, the help that was being given to them. So there's ways in which we're trying to address those behaviors. I know implicit bias is a term that we don't use anymore because we're going to call it what it is. Understanding racism and white supremacy and that our system in the United States, our country is built on white supremacy, on from how you look and how you appear. I mean, look at from when we grew up, all the models were almost emaciated, right? White and emaciated, and had a and didn't look like what true birthing people kind of look like, with all our beautiful curves and everything else, and that things fall after a while and don't fit into the box the way they used to. And and everyone in the United States not is supposed to be a size 2. And so I'm saying that, and I'm sitting here, and Dania knows me as I am a slim person, but I do recognize the beauty of all human beings, and also to recognize that not all people that are birthing people identify as women, and not all people that are birthing people are heterosexual either. And how do we embrace all family members and all members of society, right? And the intersectionality of not everybody will say they're Black or that they're white. And what about the beautiful mixtures that we do have in the United States? Why do we have to put these folks in a box? Right? So yeah, the education starts from elementary school, because by golly, I told you I had my 2 little kids. And having them in Brooklyn and watching them go to nursery school, and the other kids that they went to school with from the time they were little, and how they really do react how grown-ups react. If it's all normal to them, to us, it's gonna be normal to them too, because they know no other way.
Right. It's learned behavior,
Yeah.
Absolutely. I totally agree with you that there's some people who say we have to dismantle the system that we have now, right? But how, right? We have to pretty much start from scratch. And like you said, scratch is when you're training them up from the start of the pipeline, right? So that when they get to these roles as providers, right, they're socialized in a way that's fair, that's equitable, and that's respectful of all people, right? So I love that. But for those who won't comply, that's what
we have other mechanisms to help you out.
Right. Yeah.
And if there's enough of us, so the other thought is, okay, but there's still going to be these folks. There's some folks that, as you do training with teams, there's some folks that are late adopters, there's some sideliners. If you have more folks that are like us, that are walking the walk and talking the talk, eventually either you come along, or you're not going to be the normal. You'll feel like the outsider if everybody else is doing it. If all of us are talking about equity and diversity and impact in healthcare and education and housing and pollution, if that is our norm, then you're going to be the outsider. And then how do you feel?
I love it. I think finally, because we are nurses and healthcare professionals, what can we all do? Where can we start in terms of turning this around?
Folks will say, oh, where do I start? What do I do? You start in your own hometown, in your community. So one of the things that in my lovely spare time, I'm very much entrenched in my community. Spare time. Because my children are, and it's cliche, your children are the future, all that business. They are, and that is why I am involved in my parent-teacher organization. I show up and I volunteer. I get to know who's making decisions in my community that impacts me, my children, and my family, of where I rest my head, and I know who's the local owners of businesses, and I support them. Those are things that we can do at the very grassroots level. And then if you want to take it a step further, I mentioned knowing who the politicians are in your local area. The politicians in your local area are elected to serve you. If you're a constituent, they want to hear from you. There's nothing wrong with going and introducing yourself and finding out what their thoughts are and do they align with yours? And then another way to do that, another step up, is to go to your state and lobby, what they call lobby, for interests of yours and special interests. That's another thing to do. There's always lobby day. And getting involved in organizations locally and nationally that have the same philosophy, thought, and mindset that you have. Those are things that we can do. As a bedside nurse, it is ensuring that you provide the same care every day to all your patients. And it's something I always strive for, even in clinical practice now. So folks will ask me about, well, my insurance cover this medication you're prescribing, and I usually don't know, because I don't know their insurance. So we have that conversation, and I do that on purpose, because I don't want to be biased and not provide a patient with all of their options based on what I know an insurance company will and will not provide. So it's providing that 150% excellence every day. And life does happen, and some days I do fall short, but that's always my goal when I encounter folks that I care for.
Awesome. So I have a few people in the room with us, and I'm just looking at Facebook to see if there are any questions. But if anybody wants to ask a question, if anybody wants to comment, you can go ahead and unmute. If you're shy, you can put it in the chat. But while I'm waiting for any respondents, anything that you want to leave with us? Final thoughts, Dr. Conterelli. I had than one last time. I'm sorry.
Yeah, no, I just want to thank you for providing me with the opportunity to spend some more time with you and all of you virtually. And I do really hope that I live to see the day that we can truly eradicate maternal mortality and racial and this construct of race. It's not something that we're having discussions about when I'm an old lady in my rocking chair.
Yeah, I totally agree. When I no longer have to have conversations with Dr. D about this topic, it will be a great day.
Right.
Be a great day. Thank you so much for joining me. Your insight was invaluable. I really enjoyed our conversation. It was fun, right? We had a few laughs. And what I want to always leave with any expectant moms that might be tuning in or tune in to the recording is to trust your body, right? To educate yourself the best that you can, to advocate for yourself the best that you can, and trust the process, trust your body. You can do this. You can have a healthy pregnancy. You can have a healthy delivery. And, this should be an enjoyable moment in your life, and not to approach it with fear, but with confidence and with joy. And that knowing that there are those like us that are fighting for you when sometimes if you can't lift your own voice, right? So more to come, more conversations like these to come. Hopefully you've enjoyed the content tonight. You can continue to follow me at I am Dr. D. I'll try to have more conversations throughout the year. As usual, my focus is always on maternal health. We may drop a few more topics in there somewhere to mix it up a bit, but this is my love, right? So we're going to keep talking about it. We're going to keep holding space for these conversations. And thank you for tuning in. Stay tuned for more, and drop me a line if there are topics that you'd like to see me explore. Thanks again.
And have a good evening, everyone.
All right, bye-bye.